Ladies and gentlemen, on behalf of InvivaScribe, we welcome you to this corporate workshop organized by the Association for Molecular Pathology. My name is Parth Sitlani, and I'm the Associate Director of Commercial for International Sales here at InvivaScribe. I will be moderating today's webinars titled Innovations in MRD Detection, Leveraging NGS to Gain Insights into Multiple Myeloma and B-ALL. I am eager to introduce our speakers for today, but first, let me go over some logistics. Today's webinar recording will be sent to all webinar registrants and will also be available both on InvivaScribe's website and on AMP's website in the education section. Handouts, including the LymphoTrack assay flyer and study of MRD technical bulletin, will be available to download throughout the webinar. If you have questions at any time during the webinar, please submit them using the questions tab on the right side of your screen, so one of our speakers or a technical account manager may address your question. Now, allow me to introduce our first speaker, Dr. Roisin McAvera. Dr. Roisin McAvera received a Bachelor's of Science with honors in Biomedical Science and a PhD in Medicine from the Queen's University of Belfast. Currently, Roisin McAvera is serving as a postdoctoral researcher in multiple myeloma and honorary lecturer at the Royal College of Surgeons in Dublin, Ireland. Dr. McAvera is particularly interested in how NGS-based measurable or minimal residual disease testing can be used to identify high-risk multiple myeloma and the potential impact on treatment. She's keen to share her published and ongoing research in this area. Our second speaker is Professor Myungshin Kim, who is a professor at the Catholic University of Korea in Seoul, South Korea. She received her PhD as well as her MD from Catholic University of Korea, and she is currently working as a professor in the Department of Laboratory Medicine at Seoul's St. Mary's Hospital, which is affiliated with the College of Medicine at the Catholic University of Korea. Professor Kim teaches courses on hematologic malignancies and has a special interest in validation and implementation of NGS-based MRD monitoring for B-cell acute lymphoblastic leukemia. I am now pleased to turn the time over to Dr. McAvera for her presentation.
So thank you, Parth, for the introduction. And so as Parth said, I am currently working as a postdoctoral researcher at RCSI based in Dublin. And today I will be giving an overview on the detection of MRD or minimal residual disease in multiple myeloma using NGS. And I'll be talking also about how we can use this to advance standardized risk classification for myeloma. And I'll be doing this referring to some already published studies, and I'll also touch on some of our ongoing work. So today's learning objectives for this webinar are firstly, to understand the role of NGS testing for MRD monitoring in myeloma. Secondly, to be able to compare NGS methods with alternative MRD detection methods and ultimately understand the benefits and limitations of NGS, including how to optimize sensitivity, standardization, and also cost effectiveness for myeloma. And the third learning objective then is to understand how MRD monitoring may aid with future myeloma management. So really we want to learn how it can be used for high-risk disease identification and its potential impact on treatment, which is supported by ongoing and published research studies. So to begin with some background on multiple myeloma, so myeloma is a hematological malignancy, which is characterized by the proliferation of abnormal plasma cells within the bone marrow. So if you look to the diagram on the right, you will see that in normal healthy bone marrow, we have production of normal healthy plasma cells, which can produce a wide range of different antibodies, which we need to fight off infections. However, in myeloma, these plasma cells have become abnormal and clonal. And instead of this normal wide range of diverse antibodies, what we have is the production of only an abnormal monoclonal antibody. And so individuals who present with myeloma will often present with recurring infections, bone lesions, and anemia. So myeloma accounts for only 1% of all cancers, but it is actually the second most common hematological malignancy, accounting for around 10% of blood cancers. The global incidence currently stands at around 160,000, and the median age of diagnosis is around 65 years, so often it is referred to as a disease of the elderly. The 5-year survival rate has greatly increased in the past 2 decades and currently stands at around 65%. And this is due to the approval of many new therapies in the last 2 decades. However, despite these, myeloma is still considered an incurable disease, as most of individuals will eventually relapse and become refractory to current treatments. So in terms of the disease dynamics for myeloma, myeloma is often preceded by 2 pre-malignant asymptomatic stages. So the first of this is known as MGUS, or monoclonal gammopathy of undetermined significance. And so these plasma cells have undergone primary genetic events, which are usually IgH translocations or hyperdiploidy, and this kind of initiates this first disease progression. MGUS can then proceed to smoldering multiple myeloma as these clonal abnormal plasma cells expand further within the bone marrow. And smoldering myeloma can then progress to symptomatic multiple myeloma, and this is normally due to the acquisition of lots of different secondary genetic events, but it's also heavily influenced by the bone marrow microenvironment. And in some cases, with people with very aggressive myeloma, may progress to extramedullary multiple myeloma, where the myeloma cells can actually escape the bone marrow and infiltrate other organ systems. So again, just to reiterate the disease dynamics and how myeloma is incurable. So you can see in this diagram that the M protein produced by myeloma cells, we see a spike in the M protein level when a subject is diagnosed with myeloma. When the myeloma is then treated, the M proteins tend to decrease as an individual goes into remission. However, the M protein levels will then spike again when someone relapses. And this continues until the point where someone may stop responding to treatment and become relapsed and refractory. And so these M protein levels will continue then to increase. So what can influence these disease dynamics? So there are kind of 4 main factors that can influence disease. So firstly, and the one that's important for today's webinar, is MRD, or minimal or measurable residual disease. Secondly, which I will touch on briefly towards the end of today, is the genetic profile of myeloma cells. And then importantly as well, therapy and the tumor microenvironment can also influence disease dynamics, but not too much will be discussed about these today. So what is minimal or measurable residual disease, or MRD? So MRD refers to a small number of malignant cells that can still persist even after an individual has received treatment. So a good way to think about this is to think of the myeloma disease as kind of like an iceberg. So what we see when someone presents with myeloma is really only the tip of that iceberg, but in reality, the disease can go much, much deeper. And the problem is that we don't necessarily have tools that can detect this low level of disease. And why do we care about this? Well, we know that if someone is MRD positive, then they have a much higher risk of relapse. So in the last few years, then research has led to much more sensitive methods, and currently the International Myeloma Working Group recommend that MRD detection methods reach a sensitivity of 10 to the minus 5, which means that we can detect 1 malignant cell amongst 100,000 healthy cells. And these tests have also been becoming much more standardized, meaning that it's easier to compare different populations. So again, just to highlight the role of MRD in myeloma, so this diagram just demonstrates that in 2 different cases where someone has reached complete response following treatment, what you can see here is that the individual who remains MRD positive despite responding to treatment has a much quicker MRD relapse. So you can see that the proportion of malignant cells increases within a shorter time frame, whereas the individual who is MRD negative in this case takes much longer before they will relapse. Similarly, then, just to reiterate that point, many different studies now over the years have shown that those who are MRD positive have a significantly poor progression-free survival and also overall survival. And so really what we can take from this is that MRD is a highly prognostic tool for multiple myeloma. So how can we detect MRD then? So there currently isn't just one standardized method that is used to detect MRD across different sites or even different countries. And so as mentioned previously, that makes it difficult then to be able to compare different cohorts. So the main methods that are currently used include ASO-qPCR, multi-parameter flow cytometry, and the focus of today, which is next generation sequencing, or NGS. So MRD detection sensitivity, how low can we go? Or in other words, how low can this disease be that we can still detect it? So really what's recommended at the moment is that we are able to detect MRD at least a level of 10 to the minus 5. And most current methods will be able to detect MRD between 10 to the minus 4 and 10 to the minus 6, with some NGS methods now even being able to reach 10 to the minus 7. However, in reality, that doesn't mean that an individual is truly MRD negative, and in reality, the MRD might be at a much lower level, but we currently just can't detect this. However, what we do know is that the level of MRD is proportional to how an individual will progress. So you can see in this Kaplan-Meier here that those who had a higher level of MRD, where MRD was present at 10 to the minus 5, had a much poorer survival than those who had an MRD level, which was much lower at 10 to the minus 6. So just quickly to summarize some of the benefits and limitations of these different MRD detection methods. So I've just outlined a few characteristics to compare. So one of the main kind of limitations of these molecular qPCR and NGS methods are that a baseline sample is required. So we need to have been able to characterize that original disease clone in order to then later be able to look at MRD. Whereas this is where flow cytometry can be advantageous because a baseline sample is not required, and so it may be applicable to a lot more people who have already been previously diagnosed. In terms of sample requirement then, the problem with flow is that it actually requires quite a lot of cells, with 5 million roughly needed to reach sensitivity of 10 to the minus 5 to 10 to the minus 6. NGS requires about 3 million to reach 10 to the minus 6, whereas qPCR requires a lot less. However, then in terms of sample processing, qPCR and NGS are beneficial as the samples can be stored normally in the form of DNA, which can be stored for an infinite time and then processed at a later stage, whatever suits the lab. Whereas with flow cytometry, this needs to be performed pretty quickly, with a sample needing to be fresh within 48 hours. In terms of sensitivity then, all of these methods have been shown to be able to reach 10 to the minus 6, but generally, routinely, qPCR would only really reach 10 to the minus 4 to 10 to the minus 5. So in this case, you could say that flow cytometry and NGS are advantageous. Another advantage then of these newer flow cytometry and NGS techniques are that clonal evolution information can be received from these tests, as we can pick up. In the case of flow cytometry, you can look at different sample types that are there, and in the case of NGS, you can look at the different sequences present in different clones, whereas this is not possible with qPCR. As well as that then, qPCR is thought to be quite labour intensive, and this is because each individual subject needs to have specific primers designed for their clone. And so this can be considered quite complex and may also take a few days. Flow cytometry has the biggest benefit in terms of turnaround time, as normally it can be performed within a couple of hours and a result obtained within a few hours, whereas with NGS, often an NGS run can take several days. And then one of the characteristics then that I will focus on a bit more today is the cost of NGS, which is one of its kind of major limitations, is that it is a lot more expensive than these other methods. So another thing to consider when assessing MRD is the sample type and the origin of the sample. So a lot of recent studies in the last 5 or 6 years or so have started to investigate spatial heterogeneity in myeloma and have shown that it is quite prevalent in myeloma. So what that means is that obviously myeloma is mainly contained within the bone marrow. However, studies have shown that depending on where that bone marrow sample is taken from, may give different results. So basically, each kind of niche within the bone marrow may be made up of different clonal subtypes. And so this obviously then can downstream affect results. To overcome this then, a lot of researchers have started to look into liquid biopsies instead of bone marrow, which is usually in the form of peripheral blood. And the benefit of this is that obviously it's less invasive, but also it can give some indication of this spatial heterogeneity. So to go through some of the benefits and limitations of these two different sample types. So with a bone marrow aspirate, this is currently the kind of gold standard in myeloma. However, as I mentioned, this is quite an invasive procedure, so it is not normally enjoyable for the individual who is having the bone marrow sample taken. As a result, then, repeat tests aren't as feasible because it is so invasive. It doesn't really give any information on genetic heterogeneity unless you took multiple samples, which again, the problem is that would lead to more invasiveness. And as a result, then, it's difficult to be able to monitor any extramedullary disease. On the other hand, then, liquid biopsy or peripheral blood samples then are, of course, much less invasive. And so the benefit of this is that repeat tests are much more feasible. It can give some information on genetic heterogeneity. However, this method is much more recent and so maybe not as standardized currently. It may also not be quite as sensitive, and this is because many studies have shown that in order to reach the desired sensitivity for these methods, quite a large volume of blood may be required for MRD monitoring, which then in reality may make it not so as non-invasive as we originally would have thought. So before I delve into how we can use NGS for MRD detection, it's important to firstly go through a little bit of background on myeloma biology itself in terms of immunoglobulin gene rearrangements. So in normal healthy B cell development, all B cells will undergo this process known as VDJ recombination, which is a process of somatic recombination involving these three different regions of the immunoglobulin genes, known as V variable, D diversity, and J joining regions. This process is necessary to be able to produce different types of immunoglobulins. So immunoglobulins produced from B cells can recognize almost all kinds of antigens due to their antigen binding proportion known as the variable region. However, in myeloma, what happens is that instead of lots of different immunoglobulin rearranged sequences, there normally will be a clonal rearrangement that takes over in those clonal cells. And so we can use this to our advantage to then monitor disease progression. So I will explain how to do that now. So MRD detection using NGS usually will involve monitoring immunoglobulin clonality. So at baseline, a bone marrow sample can be taken from an individual presenting with myeloma. DNA is extracted, and then using PCR-based assays, we can amplify up those regions of the immunoglobulin genes. And at this stage, this requires quite a low input of DNA of only 50 nanograms. At this point, because the person is being newly diagnosed, we would assume that this clonal rearrangement will be present at a high level. And so this requires quite a low number of reads per sample, so about 20,000 reads. And then we're able to use software then to identify whether a clonal VDJ rearrangement sequence is present. And if so, then we kind of refer to that as like the DNA fingerprint of those malignant cells. The subject then will go on to receive therapy, and then sometime after therapy, we can then look at a follow-up bone marrow sample. Again, we will use the PCR assay, whichever assay determined a clone at baseline will be used to amplify again up the immunoglobulin gene. At this point, we will need more DNA than previously because we expect that if this subject has responded to therapy, if this clonal sequence is still there, it will no longer be clonal and will be at a much lower level. And so in the case of myeloma, to achieve the desired 10 to the -5 sensitivity, this requires at least 2 micrograms of DNA input. And similarly then, the DNA must be sequenced at a much greater depth than at baseline. And so in this case, we would want at least 2.2 million reads. And we can then analyze the FASTQ files then using software. And at this point, then we search for that original sequence that was clonal. And if it can be detected, then we say that subject is MRD positive. And if we can't, then we say that they are MRD negative. So as I said before, NGS detection of MRD is quite expensive. So there are a few things to consider to try and be as cost effective as possible. So really the major influence of the cost of NGS is the sensitivity that a lab is trying to achieve. So the higher the sensitivity basically means you require greater depth of sequencing. And that means that on one NGS run, you can run less samples per run. So obviously then if you're trying to reach a high sensitivity, you may require multiple NGS runs, which obviously increases cost as more reagents are required. As well as that, it may not actually be feasible to reach this higher sensitivity a lot of the time, as it does require much more sample. And the other thing to consider then is whether or not a lab wants to do longitudinal MRD monitoring, so repeated tests, because obviously the more testing done, the more increased the cost will be. So I'm going to touch briefly on a bit about MRD in research currently. So one area that is quite a hot topic in MRD is whether it can be used to guide treatment for myeloma. So I've just outlined a couple of recent studies. So the first is this master trial, which was very recently published. And in this study, treatment was stopped when subjects had 2 consecutive MRD negative tests, where they used NGS reaching a sensitivity of 10 to the -5. And those who remained MRD positive then received lenalidomide maintenance. And this study showed a positive outcome for using MRD status to guide treatment. However, this still was inferior for high-risk cases. The second study then here, known as MRD2STOP, in this study, maintenance therapy was discontinued if subjects were MRD negative, using 3 different methods. So firstly, they used imaging, so PET and CT scanning, and then they also assessed MRD using NGS and flow. So maintenance therapy was discontinued if patients were MRD negative. And what they found was that MRD negativity resulted in a high rate of sustained MRD negativity and lack of disease progression. And so as research continues, this may in the future lead to MRD adapted therapy. So another kind of area of research interest for MRD is genomic profile. So again, I've just included a couple of studies here, but actually results from different studies have been quite conflicting. So in this first study here, what they showed was that despite cytogenetic risk, MRD status didn't really have an impact. So what they saw was that if an individual was high risk by cytogenetics, even if they were MRD negative, they still had a much worse survival than someone who was considered low or standard risk. However, in this second study here, they actually showed the opposite. So what they showed was that if an individual was high risk by cytogenetics, but managed to achieve MRD negativity, the survival actually improved so that it was on par with someone who was standard risk and also MRD negative. And they also showed then that subjects who were both high risk by cytogenetics and MRD positive had the most inferior outcome. So this brings me nicely on to the study that I am currently involved in. So I'm currently the lead postdoctoral researcher on a national non-interventional study in Ireland, which is led by Professor Siobhan Glavey, who is a consultant hematologist and clinician scientist at Beaumont Hospital and RCSI in Dublin. And this is the largest kind of its study in Ireland. So we receive samples from across the whole country from 7 different clinical sites. So the aim of this study is to profile the genetic risk of 122 new myeloma subjects in Ireland for the first time. And we are doing this in two different ways. So firstly, we are using gene expression profiling. And secondly, in the same cohort, then we are also monitoring MRD using NGS. And ultimately, we hope that at the end of this, we'll study if gene expression risk status correlates with the ability of a subject to achieve MRD negativity. So briefly, just a little bit about current risk stratification for myeloma. So as I've said, myeloma is extremely heterogeneous. And as a result, then the outcome for subjects is also extremely varied. So those who are considered standard risk will have a survival of around 7 to 10 years, whereas those considered high risk will have a much poorer survival of less than 2 years. So really, the problem is that there is an unmet need to risk stratify individuals. Usually, risk stratification will involve the use of recurrent genomic aberrations that can predict prognosis. And most commonly, these will be assessed using fluorescence in situ hybridization or FISH. However, FISH can have quite a low success rate and also lacks standardization, particularly between different labs. And in our case, in Ireland, all of our FISH testing is outsourced. And so normally the turnaround time is not efficient. And so ultimately the data is really lacking for Ireland nationally. And so our study is trying to address these problems. So the design of our study then, we receive a bone marrow sample from a new multiple myeloma subject who is transplant eligible. From the bone marrow then, we enrich mononuclear cells and also the CD138 positive plasma cells. The mononuclear cells then, we extract DNA from those, and we use that for the clonal characterization of VDJ rearrangements, as I described previously, using NGS. And then we also take RNA from those plasma cells and use that for gene expression profiling, which then tells us at the genetic level whether that subject is considered standard risk or high risk. The subject will then receive induction therapy followed by a stem cell transplant, and we will then receive a follow-up sample 100 days after that individual has received their transplant. We again enrich for mononuclear cells and extract DNA. And as described before, we then sequence this DNA at a greater depth this time, and we search to see whether that baseline clonal sequence is still present. And if so, we consider that subject MRD positive, and if not, then we say they're MRD negative. So ultimately then, what this study is aiming to do for the first time is to genetically risk profile the Irish myeloma population. And really, we're trying to understand who is at the highest risk of relapse. And we hope then that down the line, this may lead to risk-adapted treatment. So just to give an example of a graphical output from one of the subjects from this study, this is an output from the software for this NGS method. So you can see that this subject had a very clear clone, a clonal rearrangement, or in other words, a DNA fingerprint. And you can see this clone was present at about 12%. And in this particular, using this particular assay, a clone is defined as being at least 2.5% of the reads. So this patient had a particularly high clone. I've then shown in the pie chart there, so far we have used 2 different immunoglobulin targeting PCR assays. One of these targets the FR1 region of the IgH gene, and the other targets the IgK gene. And using both these assays then, we have been able to identify clonal rearrangements in the majority of our subjects, with just over 80% of cases having a clonal rearrangement. Just to give some examples then, so this is a subject, so again at baseline you can see this quite clear clone that is present. When we then resequenced that subject 100 days after transplant, you can see from the graphical output that there is no clear clonal sequence there. And when we ran the software, this subject came back as MRD negative. In a different subject then, in this case, this subject actually presented with 2 different clones, so they were biclonal. Again, when we resequenced after transplant, there's no clear sequence present. However, when we looked for the sequence this time with the software, this subject actually came back as MRD positive. And this is just to describe the output of the software as well for these two subjects. So the first one, who was MRD negative, you can see that the software gives information on our confidence in that result. So we are 97% confident that indeed that subject is MRD negative at a threshold of 10 to the -5. And then for our MRD positive subject, the software gives back really useful information. So it tells us the cumulative read frequency of that sequence. And so then we can get an idea of the level at which that clone is present. So I also just included this to highlight the potential for possibly using this assay to also monitor pre-malignant disease stage. So these were two subjects who were enrolled, and we then found out that they actually had the pre-malignant stage of MGUS rather than full-blown myeloma. But we had already sequenced those samples, and what we see is in both cases, there's a very clear clone present. In subject number 2, there's actually 2 clones present. And so we're going to keep an eye on these subjects. And if they do proceed to myeloma, then we will resequence them again. And it will be interesting to see if we can then track clonal evolution through from MGUS through to myeloma. So as I mentioned then, we are also using gene expression profiling, which I'm not going to go into for the purpose of this webinar. But I just wanted to highlight that so far in our study, we have identified that almost 30% of subjects are high risk using this gene expression profiling method, which is slightly higher than most other studies where reports vary between 15 and 26%. So it seems like Ireland does have quite a high proportion of high risk myeloma. So just the nature of our study then is very much so ongoing. So we have MRD results so far for 21 of our subjects. And of those, then we see about 36% are MRD negative and 63 are MRD positive. And in the same cohort, then we also have gene expression profiling results for 14 of these individuals. And interestingly, so far, we are seeing a similar rate of MRD negativity and positivity across both standard risk and high risk individuals. So this is something that we will be following as our study continues. So to conclude then, I hope that I've shown that MRD monitoring is a highly prognostic tool for myeloma. MRD by NGS can be standardized across different centers, and it's capable of very sensitive MRD detection. And in the future, this may aid with therapeutic decision making. To maximize cost efficiency then, the desired sensitivity and also the frequency of which MRD is to be tested are really the major influences of this cost. Currently, bone marrow samples are the gold standard, but liquid biopsy is increasingly becoming an alternative and does have quite a few advantages. And ultimately, MRD is advantageous for risk classification and in future may be combined with genetic profiling. So with that then, I would just like to acknowledge everyone in the RCSI Glavi Lab, as well as the RCSI and Beaumont Hospital Molecular Pathology Lab, the Galway Biobank who helped with some initial sample processing, and I'd also like to thank all the staff and individuals from our study sites who agreed to be involved in this study, as well as our funding agencies. And finally, I'd like to thank the organisers for inviting me to speak today. And I will now pass over to my co-speaker, Professor Kim. Thank you.
Thank you for the kind introduction. Hello, everyone. I'm Myungshin Kim, specialized in laboratory medicine at Seoul St. Mary's Hospital. It's my great honor to speak at this webinar. This is the presentation outline for my talk. Let's begin by defining minimal or measurable residual disease, MRD. MRD refers to the low-level presence of disease that is undetectable by conventional cytomorphology. More precisely, MRD denotes the presence of leukemic cells at levels as low as 10 to the -4th to -6th. The purposes of MRD assessment are to provide an objective evaluation of remission status and assess the risk of relapse. As a result, MRD is emerging as a key measure of efficacy for new therapies. The ideal MRD tests are recommended to meet the following conditions. First, they should be quantitative, providing specific levels that are predictive of time to clinical events. Second, the methodology and interpretation of laboratory data must be standardized to allow consistent comparison between different laboratories and across clinical trials. Third, the tests need to be broadly applicable, working effectively and regardless of pre-treatment biological characteristics, such as those found in patients undergoing CD19 targeted therapy. In some cases, CD19 seems to be a reliable marker following targeted therapy. Fourth, they should offer high throughput with a rapid turnaround time. Fifth, MRD tests should be technologically simple to perform and provide objective results. Lastly, it is preferable for this test to be relatively inexpensive and non-invasive. Now let's move on to explore the various techniques used to detect MRD in acute lymphoblastic leukemia, ALL. There are several techniques for detecting MRD, all more sensitive than traditional microscopic evaluation. These include multicolor flow cytometry, MFC, molecular techniques, and next-generation sequencing. MFC detects MRD by identifying aberrant versus normal precursors through the following two schemes in ALL. First is leukemia-associated immunophenotypes, LAIPs, which identifies unique markers on leukemic cells. Second is different from normal, which compares cell markers to those seen in normal developmental stages. For example, in BALL, abnormal cells may simultaneously exhibit both CD10, an immature B marker, and CD20, mature marker. This simultaneous expression is rare in normal B cell maturation and is therefore identified as an LAIP. On this right, you can spot the presence of abnormal cell fraction among the normal B cell maturation, referred to as DFNs, enhancing the accuracy of MRD detection and assessment. MFC is known to be applicable to over 90% of cases in ALL. Among PCR-based techniques, reverse transcription qPCR is primarily used for detecting fusion genes in ALL. Common fusions in ALL, such as BCR-ABL1, ETV6, LUNGS1, KMT2A rearrangement, and TCEP3 PBX1 constitute about 40% of cases, making them suitable for monitoring with RT-qPCR. This method is highly sensitive, capable of detecting one malignant cell among 100,000 healthy cells. In terms of sample type, bone marrow is generally preferred, while peripheral blood can be a substitute, though it typically shows a 10-fold lower level of detectable disease compared to bone marrow. Another PCR-based technique is digital PCR. This method differs from qPCR by partitioning the sample into thousands of individual droplets or arrays, each undergoing separate PCR amplification. After the PCR reaction, the fluorescence of each droplet is measured, classified as positive or negative, and then quantified. It is highly sensitive and provides absolute quantification. NGS allows for the simultaneous analysis of multiple genes, enhancing both sensitivity and specificity. This technique has broadened its applications across various fields, including MRD detection in ALL. In ALL, leukemia-specific mutations like NRAS, KRAS, and IKZF1 serve as useful MRD markers. However, the most valuable MRD markers in lymphoid neoplasia are the clonality of immunoglobulin and TCR genes, leveraging the natural process of VDJ recombination. We are now focusing on using NGS for Ig clonality for MRD. We'll review the primer and experimental processes, defining clonotype and sensitivity as well as normalization. Additionally, we'll compare IgNGS with other MRD techniques. The primers used in NGS for Ig clonality assay are shown here. For the IgH gene, threefold primers are used targeting the FR1, 2, and 3 regions, with an inverse primer targeting the JH region. For the IgK gene, fold primers target either the VK regions or introns, while inverse primers target the JK regions or KDE. The workflow of NGS for MRD is depicted here. Initially, samples are collected and sequenced to identify what we call index clones using the gold standard or IgNGS methods. These sequences, same as index clone, are continuously tracked throughout the patient's treatment and beyond. In case of relapse, the sequence of clones detected in the relapsed sample should be compared to that of the initial clone. This comparison allows us to study clonal evolution and assess the drug response at the time of relapse. What is a clonotype? A clonotype refers to a unique VDJ nucleotide sequence that identifies individual B or T cell receptor. However, due to subclonal heterogeneity, a context-specific definition is often necessary. Metaclonotypes are defined in the context of stereotype, referring to unrelated clones sharing quasi-identical VDJ rearrangement. In the context of the BCR, metaclonotypes are observed in response to vaccination, infection, and virtual B-cell malignancies. For TCR, metaclonotypes are associated with infection, GVHD, anti-tumor response, and T-cell lymphoproliferations, such as T-LGL leukemia. Subclones arise in the context of intraclonal diversification within Ig genes due to the presence of somatic hypermutation variants. How do we define a malignant clone from IgNGS data? A malignant clone is typically defined as a clonotype comprising more than 5% of all rearranged VDJ sequences. The index clone, the one with the highest frequency, is used for tracking MRD. It usually makes up at least 3% of all sequences and 0.2% of all nucleated cells. The criteria may vary depending on the specific kit or company, and some base their criteria on the total lead count. While sequences that match exactly are considered a part of the same clone, we account for biological and experimental variability. So sequences up to 2 base pair mismatches are commonly considered as the same clone. Additionally, it's not uncommon to track sequences of multiple clonotypes when monitoring MRD. Clonal burden is presented as the proportion of index sequence release divided by the total number of sequenced amplicons. As you can see in this example, we were able to identify the same sequence as the index sequence at 0.023% after treatment using IgNGS. What level of sensitivity is effective for detecting MRD in ALL? The recent NCCN guidelines recommended MRD assessment using technology with a sensitivity at least 10 to the negative fourth. Interestingly, they guided an additional IgNGS assay, specifically in cases showing MFC MRD negativity, to confirm true negativity given the higher sensitivity of NGS. So how can we get enough sensitivity? The sensitivity of NGS primarily depends on the amount of DNA input and read depth. It means that the greater the DNA input, the more sensitive the test becomes. The read depth depends on the composition of B lineage cells in the DNA. To achieve the sensitivity of 10 to the negative fourth, at least 200 nanogram of DNA is required. However, if we aim for a sensitivity of 10 to the negative sixth, 20 microgram of DNA should be used. Using this calculation system, we can conveniently achieve the expected sensitivity with greater confidence. After setting the amount of DNA to 400 nanogram with 500,000 read depths, we can achieve a sensitivity of 10 to the negative fourth with 99.33% of confidence. Another way to increase the read depth of MRD samples is by modifying the library pooling protocol. After determining the library size and quantifying the libraries, we can plan the dilution calculations to maximize output. Alternatively, or as additional support, purification kit can be used. Normalization is a critical process for exact assessment of MRD in ALL. Actually, during PCR, the products only come from cells involved in the series of B cells rather than total nucleate cells. This means that the proportion calculated from the previous formula represent the MRD in B lineage, not in total nucleated cells. This is where normalization becomes essential, as it converts the calculated proportion of MRD into a value based on TNC. Several approaches have been proposed for normalization, including using different plasmid-containing known IgG gene rearrangements, and spiking synthetic or known control templates at limiting dilution in each sample, and adding a defined amount of buffer coat as a spike-in control. And they are widely adopted and helps provide normalization results for NGS. Next, we'll look at specific studies comparing IgNGS with other techniques. Recent studies show a good correlation between MFC and NGS. IgNGS demonstrated superior sensitivity in detecting low level of MRD, making it possible to identify these levels in both pediatric and young adult BALL. You can see the good correlation between NGS and RT-qPCR with an overall concordance rate of 69% of BCR-ABL1 positive ALL. We can observe PCR positive and IgNGS negative cases here, and their discordance is explained by the presence of BCR-ABL positive non-leukemic cells that are not involved in tumorigenesis. Now, I'm excited to share our experience with IgMRD in BALL move forward. This case study was initially conducted to evaluate the performance of IgNGS for MRD assessment and identify key considerations. The retrospective study included samples from 47 subjects. We selected a good prognostic group with T1221 and poor prognostic group with T922, along with other cases. We then compared the results from IgNGS with those from cytomorphology, conventional IgQ-PCR, RT-qPCR, and fluorescent in situ hybridization. We utilized LymphoTrack with up to 200 nanogram of DNA, and the malignant clones were defined based on the following recommended criteria. It turns out that IgNGS could detect Ig clonality in all included BALL cases at diagnosis. The IgHFR1 assay was positive in 42 subjects. The clonal distribution was as follows. Of the subject, 46.8%, 22 subjects has a single IgH clone, while the remaining 25 had 2 or more clones. These clones could be used for MRD assessment. IgNGS also demonstrated good correlation with other MRD detection techniques, morphology, and RT-qPCR and FISH. We also observed an interesting finding. In cases with more than 2 coexisting clones, each individual clone responded independently to chemotherapy. Meanwhile, satellite sequences with minimal differences from the dominant clone reacted in parallel with their affiliated clone after treatment. The next case study, published in 2022, focused on pediatric BALL. We enrolled samples from 55 pediatric BALL subjects, including the listed genetic subgroups, and compared IgMRD with MFC, both with a sensitivity of up to 10 to the negative fifths. To maintain this sensitivity, we increased the DNA input to at least 400 nanogram. In this study, we highlighted the necessity of normalization. We designed a normalization method by estimating B-cell population in the sample using flow cytometry or immunohistochemistry, and compared the normalized results with those obtained using the LymphoQuant internal control. Both normalization showed good correlation, and the correlation between normalized IgMRD and MFC was stronger compared to unnormalized IgMRD. Additionally, we found that normalized MRD had a stronger prognostic impact than unnormalized MRD. Through this study, we found that MRD normalization as a percentage of TNCs using LymphoQuant cannot be overemphasized, as it made IgNGS a significant prognostic indicator. The final topic of my talk is the quality control of IgNGS. As we all know, it's essential to include both positive and negative controls in each experiment as provided in the kit. Additionally, the use of LymphoQuant for normalization, along with a low positive control for accurate quantification, is beneficial. An external quality control program was also deemed necessary, including interlaboratory concordance using clinical material or synthetic materials. These figures impressive demonstrated excellent interlon and interlaboratory reproducibility. This consistency across different runs and laboratories highlights the robustness and reliability of the method for precise quantification. In Korea, the Child Cancer and Rare Disease Project was initiated in 2021. This project has endorsed the use of IgNGS MRD assay and contributed to building a comprehensive database and protocol for pediatric hematologic malignancies. IGNGS has been implemented in various laboratories with an external QC program designed to harmonize the MRD results. We have completed the first round of QC material testing and hope this effort will help standardize IGNGS for BALL. In summary, IGNGS is becoming an indispensable tool for detecting and monitoring MRD in ALL. The use of IgMRD testing is expected to grow in the coming years. The superior sensitivity of NGS improves both disease monitoring and outcomes. However, normalization and quality control are essential for ensuring accuracy. Further advances in MRD analysis should focus on achieving reliable and broadly applicable results through standardization. These are our team members and co-workers, Catholic Genetic Laboratory Center, and the researchers and pediatricians and hematologists, whom I acknowledge for their enthusiastic research effort and several commercials dedicated our research support to our research. Thank you for your attention.
Thank you, Dr. McAvera and Professor Kim, for your excellent presentations and introduction to advanced MRD techniques to assess multiple myeloma and BALL. Again, I'd like to remind you to download the handouts using the tabs on the right and submit any questions using the questions tabs on the right of your screen. We have now reached our closing time. On behalf of AMP and InvivaScribe, we want to thank everyone for your attendance at today's educational webinar. We also once again thank Dr. McAvera and Professor Kim for their fine presentations. Thank you.